Okay, well, Colleen, thanks a lot for the introduction, and thank you all for joining us. Just a bit of personal background. So I'm a health policy generalist, and I'm not an expert on pharmaceuticals. And why did I come to speak about this topic was that Colleen had invited me to come speak earlier this week, a week ago, at a conference in Toronto. It was about the future of Canadian Medicare, and had a few people from different countries, and she asked each of us to come and speak about interesting things in our country that might be relevant to Canada. And I said, I'm not an expert on Canada, but I can tell you some of I gave her a list of about 8 interesting things that I thought were going on in Israel, and one of which was that we're pretty good at keeping pharmaceutical costs down. So she picked that one. So then I quickly met with my pharmaceutical expert friends, like the equivalents of some of you people in the audience, and together they really helped me put together this presentation. That's the background. And this jump into this. Okay, so the starting point is that we are a really low spender. This is from the OECD data, and this is not age adjusted. It has us being about 1/3 of the level of Canada in terms of per capita pharmaceutical expenditures. We have a younger population, so after you adjust for the ages, we're about half the level of Canada. And I'll start with a quick overview of Israeli healthcare. Then I'll talk about some of our strategies for containing pharmaceutical expenditures. And then if there's time, I'll also talk about some of my perceptions so far from talking with Canadian colleagues of which of these Israeli strategies might be adaptable to Israel. But of course, Matthew and the audience will have more to say about that. After I finish the quick overview of Israeli healthcare, I'll pause for a couple minutes and see if people have any questions of clarification about that. So we think we have a really efficient health system. We're relatively low cost. I'll show you some slides about that in a minute. And our health outcomes are pretty good. We're set up with national health insurance. Everybody's covered. And everybody has to and can pick between the 4 competing HMOs or health plans. HMOs like Kaiser, and they're in charge of, the government defines the package of benefits to which everybody is entitled. And then when you pick your health plan, they have to give you that package of benefits, either themselves or to buy those services for you. In return for that, they get from the government a capitation payment based on how many people are in each health plan, as well as their ages. Because of course, older people cost more, so you have to give the HMOs with more older people more money. And they are a nonprofit, and they compete with one another for members. They can be very hard for members, and they have this because they're budgeted. It's based on how many people they have. It's not. They have this incentive to be really efficient. They want to give better services, better care, but stay within the budget. And the smallest one is 500,000 people. The largest is 4 million people. Overall, we have a population of 8 million people, and all 4 of them are quite well-run organizations. On the one hand, they have a heart. They're nonprofits. I'm not saying they're perfect, but they actually have a mission, which is to care to people. On the other hand, there's a lot of business sense in it and corporate approach to organizing things well. Another thing saying that we're very proud of Israel, we invest a lot of energy in learning from other countries. We realize we're a small country, we're 500,000 people. We don't have diversity of provinces, it's a unitary system of government. So we know we need to go outside for new ideas. And we do it very deliberately. Faculty cannot move ahead unless they spend sabbaticals or postdocs abroad. We budget into our people in government, people in academia are always going to conferences abroad. We're bringing a lot of people in from other countries. We don't think you can copy from another system, but we think that by looking at other systems, you get ideas, you get inspiration, you see that it's possible to do it differently, and we invest a lot of energy into finding ideas that might work for us and then adapting them to Israel. And if you're interested in hearing more about our strategies and how we do that, we can talk about that later. We have some problems. One of them is that the interpersonal side of care is not as good as it ought to be. We have waiting time issues, as you do in Canada, and we also have private financing, both on the delivery side and on the insurance side, which are growing, and they're creating problems for the publicly funded system. More people, or the doctors spending more of their time on the private hospital across the street, with all the problems that creates for equity as well as efficiency. So some numbers in terms of GDP, we're under 8%. If you look at it in terms of dollar terms, these are U.S. dollars. we're even lower because our GDP per capita is lower than these reference countries. Our life expectancy is quite good, and also if you look at infant mortality, quality of care, primary care system, we look good on all those measures, even compared to countries that spend a lot more than us. So that was my overview. Any questions before I move on to the more specifically about pharmaceuticals? Questions, comments? Okay. All right, so again, the pharmaceutical story starts with the fact that we spend so little money, and how do we do it? So I'm going to talk about 7 different things that we do, and many of them I think are not unique to Israel, but these are what we do in Israel, and some of them might be a little bit wrinkled from other countries, and some of them you already have in Canada, and some of them you don't, but I'll just tell you our story. So the first one is how, when we have a national formulary of things that are covered by the National Health Insurance System, which drugs. I'll just start with, unlike Canada, we have international health insurance. We have not just hospital care and physician services, we also have pharmaceuticals. It always seemed to us that was a natural part of healthcare. So there's all these new technologies coming out all the time, and they're good. And we want to have all of them, but we can't afford it. So what we do is we have this annual process. It starts out with the government, the cabinet, saying, all the ministers together saying, this is how much we can afford for new medicines and other new technologies this year. And it varies somewhat from year to year, depending on how the country's doing economically and other competing factors. And so they decide, okay, we have, let's say, 400 million shekels this year. And then there's a committee, which includes people from government, but also people from the health plans and the hospitals, and the Medical Association, the Pharmacy Association, the Nurse Association, and the general public, and a rabbi, and a qadi, and they sit together, and they get this 400 million, and they get basically to decide what to do with it. Officially, the Minister of Health has to sign off, but he's, in 15 years of things in operation, he always signs off. Now, they're all volunteers, or they're paid by their, employers. The government doesn't pay them. But they're supported by a staff committee within the government from the Ministry of Health, which really does the analytic work of, you get all these proposals in from pharma companies and disease patient associations and medical societies, and they analyze those things and put it, here's the cost, here's the benefits, here's what we know, here's what we don't know. They also have their own economic subcommittee from the committee, and so they both analyze, and they also negotiate. Well, they don't officially negotiate. They have discussions with the pharma industry. So they'll say to the pharma company, your drug is really important, looks really good, but at $500 a pill, it's going to be hard for it to compete with this other stuff this year. Maybe you want to reconsider, $400. So they have those discussions about prices, and it's taking place in a context where they're not looking at each drug separately. All the drugs are being considered at the same time, right? They're competing with one another, subject to a budget constraint. Everybody knows that, okay? And they don't just put pressure on the companies with regard to price. They also do with regard to volume. So the company will say, it might be $500 a pop, but it's only going to be 200 patients. It's a very rare disease. And the government people say themselves, and the staff say, yeah, we heard this story before. They say 200, but it's really going to be 2,000. So they say to the company, we really think this is a really important drug, and now the price that you came down is okay, but we're concerned it might not really be 200. How about if it's we think it might be more like 2,000, and the company says no, it's really 200, maximum 300, for sure, not more than 300. We're in the Middle East. It's a bazaar, right? So then the committee will say, well, if you're so sure that it's 300, I assume you'll have no problem taking on the risk. If it's over 300, you'll cover the costs, right? And then the company says, well, okay, over 500 we'll take on the risk. So it's a risk-sharing kind of thing. And what I'm saying is, it's not so unique to Israel, but that's the way we do it. Anyway, so then they have these tough decisions about where do you put the money? Do you put it in the cancer drugs that are, nobody could afford otherwise, but are only going to extend life? They're only for a few people, so it doesn't add that much to the total bill. So, a lot of money for those things that are a lot of money for a little bit of people, or the things that are a little bit of money for a lot of people. And I'm sure you can play out what and what do you do for things that only extend life by 2 months or 3 months? But there's a demonstration outside your office saying this is really important because people know that they're the ones. Anyway, there's a lot of public involvement, a lot of media coverage, and this serves really to educate the public about A, that we have constraints, and B, that we want more. So on the one hand, the fact that there's a budget lets the finance people feel that the system is not out of control. They know how much it's going to be, and they know pretty much how much it's going to be the next year because it doesn't change that much year to year. So they feel calmer. On the other hand, the health people feel that they get to make their pitch in the public eye. And if there's really important stuff come down the pike, let's say with this new hepatitis drug or it's going to be more biologics, it's a way to prepare the public to put pressure on the politicians to they know what's at the margin, what are they missing out on, and a lot of media coverage on this. Okay, so we also, second thing we do is we really care about prices. This is the first part that I already talked about, that before things go into the benefits package, there's this gentle persuasion going on. But it doesn't stop there. After the government sets the maximum price, the health plans, who are the main drug purchasers, and they're big, will be pushing for discounts from the drug companies. So it's you get two shots at knocking the price down. We have a pretty efficient distribution system. So the health plans or the hospital associations will be big purchasers. Either they'll distribute it through their own network of pharmacies, or there'll be big pharmacy chains, which are pretty well run. And so you don't have big mom and pop stores with, we have efficiencies of scale in our distribution. And I think this might be the most important thing, and I think this is the thing that's probably most difficult to translate to Canada. We put a lot of energy into making sure that into affecting prescriber behavior. It's one thing to work at the macro level, decisions that governments can make, and those are tough enough because there's obviously competing interests, but it's only one place. But a lot of the stuff, where the stuff hits the fan, is that when the provider has to give health care, thousands, tens of thousands of providers giving health care to millions of patients, right? Which drug will they prescribe? How much will they prescribe? For how long will they prescribe it? What will they do to encourage adherence? So in our country, because the physicians all work for the health plans, either on a salary basis or on a capitation basis, the incentives are lined up because they're not into fee-for-service, and they have a huge amount of support from these health plans. We were one of the first countries in the world where every primary care doctor was connected to a health information system, a modern health information system. We now have National Health Information Exchange where the health plans are hooked up with the hospitals. So you really have lots of information about your particular patient, and that enables the health plans to give messages to the prescribing physician who starts to prescribe something expensive, B, and it says, well, if you really want to do B, you could do it, but we really think A, the computer system, the intelligence embedded in the system is saying, but we really think A, which is half the price, you really don't do that. And so some drugs, you could do an override right away, but some drugs you have to call a number and convince somebody to make the override. So it's the information systems, it's the contra-detailing of the detailing work done by the drug company reps, it's physician education, it's managerial structure. If someone's a consistent outlier, you won't fire that doctor, but you call them in for a discussion. It won't be a lay person, it'll be another doctor calling it, a managerial doctor calling them in and discussing and helping them understand. So a lot of work goes into helping people make efficient and effective prescribing decisions. Oops. Okay, another thing we do, which I think you do also in Canada, is we don't allow direct-to-consumer advertising for particular drugs. We do allow, under certain conditions, direct-to-consumer advertising for classes of drugs or types of drugs. So that's something we do. And here's an interesting thing. In Israel, our big drug company, can anybody know the name of our big drug company?
Teva.
Teva, right? And what kind of company is Teva? Generic, right? So our industry pressure is pro-generic, right? If you're sitting in the U.S. or you're sitting in Switzerland, the industry pressure is for patented drugs. And of course, every country makes that, has to balance. We do respect IP rights, and we do want to give investors appropriate returns to innovation. But if your local champion is a patented medicine company, and on the other hand, you also want to keep costs down to ensure access. So if you're sitting in Switzerland, obviously, it's not going to be so easy there. They'll also have generics, of course. but it's not the legislation, the regulatory framework won't be set up to give push to generics. And in Israel, we are very much in the paper. If you want to see it, we have a list of things that we do, some of which other countries don't do. But let's say if generics have been registered in any of 30 countries already, 30 serious countries, then it's very easy for them to move ahead quickly in getting it registered in Israel. So there's a whole bunch of laws that are very pro-generic. Now here's the last thing. The things I talked about till now were all very practical, nuts and boltsy kinds of things, but underlying that is an approach and a set of shared understandings that people in Israel have. And that's very important because you want to make changes. If the set of beliefs, if the concepts are very different, it's harder to move ahead. So I think very broad sets of people in Israel would say, A, pharmaceuticals are good stuff. They really help people. They can be very cost-effective healthcare. We're not against the drug companies. We need to be tamed, but we think that they're doing an important job. B, we don't have enough money to do it all the good stuff. There's more good stuff than we can afford. We gotta have roads, and we have to have education, and we also have to have armed forces. So those things take up money. C, in light of A and B, we have to prioritize. There's no way of getting around it. It's not death panels. There's no other way. We have to prioritize. And D, that when we prioritize, it makes sense to focus on the most expensive and the newest stuff. And that's where the energy goes in the prioritization. So the cost-cutting themes are that we have a lot of involvement of stakeholders, that we work not just on price but also on quantity, that it's not just all in government but the non-governmental agencies, particularly the health plans, are very important players, and that we pay attention not just to practices but also to beliefs. So, I don't know, should I stop here? Because I could give some, if I have another few minutes, I would talk about this topic.
Yeah, sure.
Okay.
You've got like at least another 10 minutes.
Okay. So,
and we could bargain about that.
Okay. No. So
but that's a hard resource constraint.
Okay. Yeah, you're the boss. As we're all in the room here, that we're thinking about, Matthew's going to lead us off, but as we're all going to be thinking about what it is Israel might be adaptable to Canada is, it's important to know about in what ways pharmaceutical policy is not in a vacuum. It takes place in a broader context. So what are some of the similarities and differences? So you're this huge country, and we are this tiny country, and maybe that's important. Maybe not. A lot of things are similar. We have both countries with universal coverage, we have single payers, and we have good health status, basically good health systems. We're spending more than you do our private financing. If you're worried about yours, ours is more of a challenge. So I talked about the geographic size. The federal unitary thing is obviously complicated to make big changes in Canada, partly because of the federal system. So the things I mentioned. And I think perhaps the most important thing is we have these health plans, which are this huge resource for us. They're this engine of innovation and efficiency, of experimentation and finding things that work and then spreading them nationally. And I think you don't have stuff like that here. And you're unlikely to invent it. It wouldn't fit your culture, and it would be too big a change. So the things that we do through health plans, are there other ways to do it here through cooperation between physician associations? And I'll tell you something, when I was preparing this talk, so I asked Colleen and others to put me in touch with people in Canada to help think about it. And most people that I talked to didn't talk about it. They were talking about the real macro stuff and not so much what happens at the coal face. And when I said, not Colleen understood, but to the other people I talked to, I said, who can I talk to in the physician association? And they said to me, why would you want to talk to somebody in a physician association? We're talking about pharmaceuticals. So there was like this disconnect, which was, for me, very interesting. Mm-hmm. Okay, benefits packages are pretty much similar, except in pharmaceutical care. And mental health care, the aspect of health care is part of health. And that's about it. So I think I'll stop there.
Okay, so I took this as given my background as a response from New Zealand, and try and have a look at what are some of the similarities here, and therefore what matters. So, but first I wanted to start with the similarities right up front from a statistical macro point of view, and you see down the bottom here a group of countries essentially that have per capita spending around the same level. There's quite a jump to that group. And among them is New Zealand and Israel. Now, I have to credit Marc Andre with this slide because I could not get this information from the OECD data alone. I think you've melded it with some Kai-High data too.
Which explains why the slide is in French.
Yes. Even though I'm perfectly bilingual, not. So, you know, Israel and New Zealand have something in common right from the get-go, and I think it's kind of interesting to look at those elements as a result of that. But before I go there, I'm looking at the critically minded in the room and asking the question, well, as Bruce notes in his paper, or maybe this is just all age structure, or maybe it's, you know, the fact that New Zealand has a really old formulary, you know, that all cheap drugs, hasn't renewed its formulary, or maybe there's just some serendipitous reason for it ending up in this place, and it's got nothing to do, in fact, with active management of the formulary. In actual fact, when you look at the data in New Zealand in particular, you look at all the decisions that are taken in this instance between the base year of 2004 and the reporting year of 2015. If you take out all of those decisions that affected price and left volumes and mix at the same level, what expenditure would you get? Well, you get somewhere around double what you have at the moment. So there's a lot of active management going on. You don't get to that around $300 per capita expenditure just on serendipity alone. Well, maybe it's that New Zealand is stopping access, essentially, you know, through some sort of co-payment regime. Well, as mentioned by Bruce, they've got low co-payments. Here's a slide comparing New Zealand with Australia. New Zealand has very low co-payments. And as part of that co-payment system, it has a very low threshold. So an annual threshold, once you go over that spending, you then pay nothing, essentially. It drops to zero. So it's not a financial barrier that's controlling this. And likewise, is it just an old formulary that's not advancing? Is it that New Zealand somehow or other is just controlling volumes, you know, and not letting people get access through other means? And the fact of the matter is, when you look at their last annual review, 3.2% increase in volumes that year, while spending remained exactly the same. And at the same time, actively adding new drugs to the formulary. So we've got basically a modern and growing formulary. We're not restricting access, financial access, and we're still managing to get per capita expenditure at this kind of just below $300 mark. So I would suggest there's something in the policy environment or actively being done to make that happen. So what is it? Well, just let's start off with the key features of the New Zealand Drug Plan, and then I'll match those with the 6 strategies that that Bruce has talked about. So there's one plan, universal coverage. It's not a plethora of plans. It covers all residents. I've talked about those issues there. It's funded through general tax and a fixed budget. Now there's an element of difference here between what Bruce talked about, the fixed budget being for a pot of money for new funding, new products. Here in New Zealand, it's for everything, right? You have to manage your entire formulary within a fixed budget. But again, like the Israel system set by the minister, in this case it's a 3-year envelope, but because it's managing something a little bit different. But then the listing decisions, etc., are managed by a Crown entity that sits at arm's length from government, appointed by the minister. It's a board that has this responsibility. The minister, in effect, has to sign off in much the same way. The minister can direct, but in 25 years, I think, well no, 23 years now, the minister has intervened twice. And this last element of the New Zealand system is a feature that, you know, you can say, okay, you need an arm's length government agency and let them go and do the job. But they have to be a well-performing agency. You know, they really have to have the notion of managing to a budget constraint, in their DNA, essentially, and thus opportunity costs are magnified as a result, and you have to make choices, and you have to try and make good choices. That in itself doesn't always happen, and you know, there's an interesting discussion to be had, I think, around this public committee that Israel appoints, and whether some years they do a better job than other years, and you know, like what is the feature of that makes it work well. So let's go through those 6 strategies, and I just want to quickly compare them and then talk about, as a consequence, what matters. So a fixed budget and prioritisation by a public committee, and this is for additions to the formulary. So what's happening here is, in that process, prices are being re-evaluated, values being assessed, value for money is being estimated, risk sharing agreements are being discussed and put together, and that whole proposal for the listing of a product is being assessed and against every other proposal that's trying to get some of that budget. And in essence, they're being forced to exercise choice through that process. Well, this is pretty much identical to what happens in New Zealand. There's a major difference here though. New Zealand doesn't do it once a year. It basically does this prioritisation process continuously throughout the year. But what it does do is put some instruments in place to essentially force it to make prioritisation decisions at 4 points in the year. It does it quarterly as a quarterly prioritisation meeting within its own organisation, where it adjusts what is at the top of the list and what isn't, and consequently deals, you know, is making deals with people, with the proposers, for the purposes of assessing whether or not that is the best option for spending at that particular time. And if those deals don't eventuate, then they go down the list. Or if they do eventuate, then the deals get done. And you know, it's trying to constantly make these decisions on a rolling basis throughout the year, so that expenditure in that year, and in fact expenditure in the forecast envelope, actually remains within budget. Fair and reasonable price. Now, I got this wrong from Bruce's paper. So I assumed that in terms of this committee making these decisions about these products, they have a proposal in front of them, and that proposal gets accepted. And then you've said then the organisations get to have another bite of the cherry and say, okay, can you do a better deal? Can you give us a better price? And we'll come back to it, I guess, but there's a real question there in my mind. Well, what if they say no? Can they refuse the deal at that point? You know, and say, okay, well, we're just not going to fund it, because we now find that locally in our own local budget, we don't have enough money for whatever reason. But, you know, the idea here is the same. It's just that I translated this into a New Zealand context, where essentially these strategies of price negotiation, risk sharing, tendering, exercising, buying power is applied to everything that's already on the formulary, everything that's already listed. So you're constantly going through and looking for opportunities to make savings of money that you can release, obviously, to put towards new drugs. The one thing that New Zealand doesn't do is this element of price regulation up front. So essentially its entire instrument for gaining reasonable and fair prices comes through commercial strategies. It doesn't come through price regulation. So there's a difference. Efficient pharmaceutical distribution system. You know, most developed countries have these sort of approaches to pharmaceutical distribution. They have importers, wholesalers, retail sectors. Some of them are sort of like corner store kind of approaches in terms of the ownership structures. Others are large multinationals that you know, have various distributors in various parts of the country. The one thing I will say about this, I've left it out of the discussion just to come in terms of what I think matters in terms of you know, getting on top of expenditure, pharmaceutical expenditure, is that there is actually a lot of price competition going on within these distribution systems. And but the price competition basically benefits the pharmacy, essentially. So in order to get your product onto a shelf, you essentially have to give rebates, essentially, to the pharmacy. Now, Canada's been trying to wrestle with that problem, and again has approached it from a regulatory point of view. Let's try and stop these bonusing arrangements from some sort of legal point of view. You know, if you have other means by which to encourage price competition from the purchaser end, then those savings tend to go to the purchasers and not to the pharmacists themselves, not to the pharmacy chains. So while it can be said that, you know, both systems have efficient distribution systems, there are these little wrinkles inside the system that I think, you know, some policy instruments can have a better effect on than others. So it's an area where I think, you know, we always need to think about and work towards. Promoting effective prescribing behaviour. Now, you know, Kaiser Permanente is probably one of the greatest examples in the world, an HMO that, you know, that really effectively manages its pharmaceutical expenditure based in the US on the basis of this, essentially. Now, the reason it can do that is all its doctors are salaried, and all its doctors have targets that it has to meet. Now, in Canada, of course, it's a fee-for-service arrangement. The docs, the family docs in particular, and in fact most hospital docs are on this fee-for-service structure. So their independence makes it far more difficult to actually coordinate them, right, and enable them to, you know, to agree to be essentially controlled or to put some controls on their own prescribing. You know, this right to prescribe is something that I earned through my clinical training, and therefore I'm going to hold it independently going forward. And, you know, so this is a little bit of where context really makes a difference. And, you know, the thing that made a difference in New Zealand around this was actually to try and give prescribers some sort of financial incentives. So what they, you know, and it's waxed and waned. At times New Zealand's had more of it, and other times it's got rid of it. But the idea of the clinicians, or a group of clinicians, holding a budget for pharmaceutical expenditure. And thus, if amongst themselves they've got a very high prescriber, you know, completely an outlier, then they will descend on that person themselves individually to try and control it. What they gain from this is the savings they get to share in their distribution. So the share of the savings that might go into their own practices, not for salaried purposes, but simply to enable them to engage in other sort of healthcare programs. So again, I think when we think about Canada, given the strong fee-for-service culture that's here, I think, you know, one of the key things Canada needs to think about is how it brings budget holding incentives to have an impact. Because there's no doubt, I mean, a lot of these strategies we're talking about the supply side of drugs, controlling the price, controlling access, etc. And the demand side really can make a big difference. But it can also make no difference. You can put a lot of money into demand-side campaigns and it does nothing. The physician prescribers have to have financial incentives as well. They can't just have clinical incentives. Avoiding artificial inflation of consumer demand. Essentially, this is the idea of prohibiting direct-to-consumer advertising. Well, interestingly, New Zealand doesn't do that. DTC is completely permitted in New Zealand. Now, one of the things, you know, New Zealand's kind of had lots of clinicians argue that this is an absolute necessity, and the government, various governments have tried to kind of get it into place, but because it was already in place, it's been jealously helped by the industry. But I would argue these days it virtually makes no difference. Because unless you're going to get involved in censoring the internet, all of that consumer advertising comes at you mainly through that source. And in the case of Canada, most of it, again, comes across the border. So, you know, Canada has prohibited DTCA, but most of its programming is watched out of the US. So, you know, DTCA is not something that is perhaps an environmental variable that you can control. You're kind of going to have to just accept that it's there and have something around it to basically make it easier for physicians to actually control their prescribing behaviour. And finally, striking an appropriate balance between the respect for IP rights, access and cost containment. Now, Israel has a shorter patent life. That's interesting in itself that it's managed to achieve that. Like New Zealand hasn't. New Zealand has long patent lives relatively because it's had to sign trade agreements with large nations, etc., and has done that to get other benefits for itself. But it does have all of these other things. It has generic substitution, more or less. It's not legislated, but it's effectively there's a means by which that's made possible, basically through the administrative system. And one of the key ones that Bruce talks about in his paper, I think, is the regulatory hurdles for generic manufacturers. And the idea of having mutual recognition for, over here we call it notice of compliance. In other words, getting acceptance by the regulator that your drug does what you say it does. And so you have these speedier processes. In a sense, you have a means by which to facilitate generic access or the uptake of generic products. And I think that is something that needs to always be thought about and attended to, and debatable whether that's really done sufficiently here in Canada. So what appears to matter if we think about N of 2? Maybe if we go back to that first slide, it was N of 2 of about 5 countries in that sort of $300 block. So maybe it's better statistics than we think. So I mean, I was struck the first thing I read in Bruce's paper was a fixed budget. It's like I've been saying it for years. New Zealand's been saying it for years. It's kind of like so obvious you had almost forgotten about it. But to me, it's just as clear as well. I've got some vernacular expressions, but I won't use them here. But it's as clear that if you have a fixed budget, you manage the downside risk of the fiscal situation. So as Bruce said, the financiers are actually kept happy, right? Because they know
they're never happy.
Well, happy enough. I used to be a Treasury official. I used to refer to us as the no bank. Come to the no bank. We'll say no. But by comparison, most pharmaceutical systems around the world use, for the purposes of deciding what new drugs to list, what new drugs to reimburse, they use a decision threshold, right? And I think this is inherently problematic because frequently that threshold is not linked to a budget. You don't effectively know what budget impact that threshold is going to have. And as your budget position changes, that threshold should be changing. And what we see throughout the world where these systems are used is that threshold remains constant and potentially goes up over time when, obviously over the last few years it should have dropped, right? So why hasn't it? And there are some other incentive effects that creates. I mean, we'll go through the list here. I was struck immediately by the committee being at arm's length from the government, from the minister essentially. So again, to me, that is something that is quite critical to being able to form a budget and make good decisions. And even if you don't agree with all the decisions, make decisions that actually can be put in place and policed essentially. There's an explicit recognition through both of those things of the need to exercise choice and essentially prioritise. And I think by setting up those processes, you effectively achieve a discussion around prioritisation that you don't achieve when you just have a threshold. Right? So, oh, well, it's got under the threshold, therefore we'll fund it. You know? But there's no idea of the notion that actually we've run out of resources despite that. And thus we still have to make some choices. There's an exercising of buying power inherent in what Bruce put in front of us. And I'd say here preferably as part of the prioritisation process. And again, I think that's actually quite an important point. Even though, for example, the two systems are quite different. It's a once-a-year thing in Israel, it's a continuous thing in New Zealand. But they're going back, and during the process, during the continuous process in New Zealand, you're returning back to the supplier and the proposer and asking for a better deal. And I was struck by the fact that Israel's doing the same thing during that once-a-year process. I almost said it before, but didn't make it quite as explicit as this. What's going on here is an assessment of a proposal, not an assessment of a drug. Right? And that's what we tend to do here in Canada, and it's what tends to happen in other countries around the world, Australia, UK. Assessing a drug, assessing its health benefits, rather than assessing the entire proposal and judging the proposal against other proposals. And I think it's kind of interesting that those two quite different processes are essentially achieving that same objective. There's a clear facilitation of generic entry and use going on in both countries. In New Zealand, there's tendering and sole supply under a tender across the entire country. Not only in the community, i.e. the family doc area, but also in the hospital. And sometimes the markets will be combined, so there's actually only one market for the generic product. Of course, this gives massive exclusivity to the supplier that wins the tender, and thus you can get really significant price reductions. But both countries are using, struck again by the regulatory facilitation of generic entry. Quite important. Use of essentially mutual recognition of other regulators around the world's market authorization. And obviously there's use of tools that facilitate competition on price. So, just the whole way it's set up. You've got a budget, you've got more options than you have money for, you have to exercise choice. Right there from the get-go. Even for a new drug, there's this notion that despite the fact that I have an intellectual property right, I'm going to have to compete on price with somebody else who's basically bidding for the same pot of money. Right? So really strong use of competitive process right up front. Now, I didn't go, and obviously effective demand side management practices, and I talked about what makes them effective a little earlier. Now, I haven't translated this into a cohesive prescription for Canada. I just think these are important elements that somehow or other within the FPT system that Canada has, one has to try and either implement, bring about, or try and mimic in some way, shape, or form through whatever instruments Canada has at its disposal. Mm-hmm. But to me, these are, if there's, I think if I sum it up right at the end with a very economic kind of approach, the systems that essentially rely on a threshold are really advertising the buyer's willingness to pay for a particular product, right? Without even giving consideration to what the supplier's willingness to sell is. Right? Now, the supplier might be willing to sell at a much lower price than the buyer's willingness to pay. And in the systems that we have with these threshold approaches and currently what we have in Canada, that's what we have. Essentially, very little ability to ask the supplier, what is your willingness to sell at? And to somehow or other share the profits between the buyer and the seller, right? Mm-hmm. And so I think what you see with the Israeli system and what you see with the New Zealand system is essentially structures that ensure that there is actually more of a balance of that going on between the buying and the selling.
Hi, Bruce. I'm Patty Patashin.
Oh, hi.
We spoke. Hello. Enjoyed your presentation. Thank you. A few questions for you, and maybe I'll pose them all and let you answer them. So I'm really curious to find out, how do you manage the existing budget? So you talked a little bit about, well, you talked a lot about the new envelope. Every year you have an envelope dedicated to sort of the competition for a new product. But, you know, what do you do? Does that budget grow? Do you expect savings from that budget over time? So I'd be curious to find out how you manage that. And then how do you decide on the budget envelope for the new drugs? Like how do you come up with that number? Also curious to find out about the transparency question. So once you reach a deal in Israel and decide what you're going to prioritize and you know, come up with your agreement at the national level as part of the price regulation, is that information available to the public? I.e., in a democratic society, can the public evaluate the, you know, how well the government has done in reaching a deal? And then last but not least, how do you deal with a drug that you really want? So it's an innovation, it's a breakthrough, it's for a condition that, you know, is unmet, and so you want the drug. The manufacturer is not willing to move from their price. Do you have, what's your, I mean, you've got carrots, but what's your stick? Do you have the opportunity to issue some sort of compulsory licensing agreement or something that the manufacturer, what's your hold over the manufacturer for a drug that you really want if they're not willing to budge on a deal?
Okay, those are some good questions. So how do we manage the existing budgets? So then it's not in the government's hands anymore. Then the health plans have to go into action, and each health plan has a head of the pharmacy department who's both an outstanding pharmacist as well as a business, a business head. And he's working with the senior doctors in the health plan and saying, and his CEO is saying to this head pharmacist, you and the head physician got to figure out a way, because this is, we got some other stuff we want to do. We want to do some, we have a waiting list, and we want to put in some more money to reduce the waiting times for operations. So he is under constant pressure. He's going to be evaluated based on that, and he's going to work with senior doctors in the system to get the message. Again, these are hierarchical organizations, to get the message down through the hierarchy that everybody's being judged on this. It's not just his problem. He turns it into the problem of the regional heads of the health plans, and they turn into the problem of the clinic manager, who then talks to each of his docs and brings in the consulting pharmacist. So it becomes everybody's problem, everybody's challenge.
Does that budget decrease over time? Because if you're
Yes.
having a new budget for new drugs somewhere else,
Right.
you would expect that for existing products that there should be kind of a gradual reduction.
Yes.
And I'm
I don't
interested
know
in
the
hearing,
numbers.
I mean, it sounds to me like it's not a silo budget for the drugs. So if you can realize savings,
Totally.
those savings can go wherever the healthcare
That's right.
system
Definitely
needs
not a
them.
silo budget, and it can work in both ways. Sometimes you really want to push a certain med because it's going to save you on hospitalizations, and sometimes the opposite. And I'll get you more detail on that later. How do you decide an annual number? So I want to rephrase something I said before. For a bunch of years, the number was pretty stable, and it's a political call, I think. You want to, even though elections in Israel don't rise or fall on your pharmaceutical policy or even your health policy, they fall on issues of defense and borders issues. But still, you want to look good. So on the one hand, you want to make sure you have enough money there, and you have to look at the politicians looking at their competing needs. Was there a major military operation in the last couple of years that chewed up a lot of budget? Is the economy growing well? But also, in the past years, have we felt that the drug budget was really, that the drug budget was really not enough? And if they got a lot of egg on their face in the past years because there was stuff that in the media looked really good and the public thought it was really good and they couldn't put it in, then they will use that. The health minister will use that to increase the budget that the overall government will give him for health. So I think it's democracy in action, the way you want it to be.
So, but is it grounded in anything? Is it like a?
No, it's not a formula. It's
just
a
a
real
political
governmental, give and take, horse trading between health, between medications and other aspects of health, and between health as a whole, with education and defense and parks, like you would want, I think. You can't run a system by formula, I think.
Does it follow the inflation rate in the pharma sector?
So again, no, it's one of the considerations. But it's like you said, it's not just what do we need, it's what can we afford. And what we can afford depends on how the economy is doing and what other needs we have and what the governmental priorities are. The government said, we're going to make a push in our 4 years, so the push is going to be in education, and health's going to be really tight for those 4 years. On the transparency issue, so I want to get back to on that after I talk to my drug buddies in Israel, but as I understand it, first of all, the official prices are definitely, at the national, are definitely publicized. I think the fact that if there are these volume pieces, transparency by us is getting better over time. The media, the public interest groups keep pushing for more and more information, and more gets out over time. In the initial years of these volume deals, I think their existence was clear, but the details were hush. I think that's changing, but I'll get back to you on that. And the health plans, when they cut deals with the pharma companies, it's totally commercial secret. What do you do when there's a drug that you really want? So you don't let the buyer, you try not to let the seller know that, first of all, right? But second of all, we don't do compulsory licensing. But we do make use of the fact that even though it's not every quarter, it's every year, and we say, you know what, maybe, we would, if there's really, obviously something really good like this new thing for hepatitis, everybody knew it was great, going to change thousands of people's lives. That was tougher. But most of this stuff is really important for small groups, small numbers of people. So you don't say no forever, but you say, well, maybe we'll think about that for next year, and that gives you some leverage.
Yeah, I think I think the test case would be some of those rare diseases drugs that are very, very expensive. That you basically got very good political economy out there in terms of making governments look bad around their decision making, etc. So I wondered myself in the Israeli system how you're dealing with those rare disease drugs, because my experience is most countries around the world are getting held over a barrel on those ones. Essentially, they typically end up having to say yes, primarily on the grounds that there are a small number of patients involved, even though the cost per patient is, in some instances, just absurdly high.
So there have been some cases where those political pressures have pushed things through. But the system's been in place enough years and it's gotten enough publicity that the general public knows that it'll kill us if we give in to those all the time. And people are used to the fact that they appreciate the fact that government sometimes has the courage and the system has the courage to say no. It's not happy for the families and the person who might not live because of that, but we live in an environment where we're making life and death decisions all the time in other sectors of our society, our economy. So it creates a certain savvy, I think.
Marc-Andre, and then up the back. Yeah.
Maybe first a comment and then a question. 3 hours ago, and exactly I think 200 meters from here at the Shaw Center, so the Health Minister of Canada, Jim Philpott, announced the most important changes in the way we're doing regulation of pharmaceutical prices for the last 20 years. So I watched the press conference, which was interesting. Basically what she announced was basically developing more e-prescribing in order to improve prescribing habits of doctors at the same time, so in terms of collecting as well the data, so this is a thing. Changing we have the capping, the system for capping prices through the patented medicines price review board. I was hoping that she would announce a change in the basket of comparator countries. She announced consultations in order to change the basket of comparator countries. So we're in this for another 18 months at least. And then saying, well, we did some fantastic things with the PCPA, the Pan-Canadian Pharmaceutical Alliance, in order to negotiate the risk-sharing agreements as well. So let's continue on this. And as well, there was one last thing.
Transparency.
Yeah, more transparency, which was interesting. I don't know exactly how they will do that in terms of, okay, we will give the payers access to the rebates we're receiving. Basically, this is what she said. I don't know how she will be able to do that. And at the same time, saying we'll push for more faster access for drugs to the market with basically more phase 4 clinical trials in order to see if the drug is working in population, which for me is a bit problematic, but it was basically which was giving back in terms of, okay, we put some pressure on prices, but at the same time we give drug companies a bit more with this life cycle approach to drugs. Still a bit disappointed about this announcement, but 3 hours ago we had the most significant changes in pharmaceutical pricing in Canada since the last 10 years. Just one question. I'm a bit confused because you mentioned your presentation that both systems are single payers, and then discussing budget, basically it seems like it's one budget in order to decide, okay, which drug in terms of innovations, which drug do we pay for. But at the same time, you have a system of managed competition between different private, not-for-profit health plans. So Clalit, I think, sorry, my Hebrew is awesome.
Excellent. So no, when I said single payer, I meant in the initial phase. In other words, all the money is raised through taxes, and government can control the amount of money going to healthcare into the system every year. So it's not like the U.S. we have all these different employer-based plans and stuff like that.
And it's not like the Netherlands, for example. Basically, you have a payroll tax, and then you have each individual deciding which health plan they will be taking, and it is the health plan that is doing basically the financing for the drug.
So for our basic plan, they don't take in supplemental premiums, but each health plan has supplemental insurance. And they compete on price on the extra things that aren't in the price.
I think the question is, Bruce, can people pick their own health plan?
Absolutely, you can switch.
Right, so you can switch your own health plan. When you switch, your tax contribution essentially
stays the same.
Follows you.
Yeah, but it follows you to your chosen health plan.
Right.
And does a risk-adjusted share follow you to your chosen health plan?
Totally.
So it's a managed competition plan.
But with single payer at the same time, which is interesting, I must say.
Same, I mean, it's pretty much the similar idea with social health insurance. I mean, however you pay it, it's kind of coming into a single reservoir of government who then redistributes to your chosen health plan.
But at the same time, having the capacity to fix a governmental budget, basically in terms of fixed budget for drugs or for new drugs, well, I think this is one tool that sometimes is missing.
Yeah. Okay. So that was the question?
Yeah.
Yeah. Okay. Up the back, and then Pradeep, and then yes.
I have a question on the budget, fixed budget, which is pivotal in both presentations. We talked about, and I think you said we talked about assessing the proposal but not assessing the drugs.
Yeah, that's that.
We in both presentations we didn't see any cost effectiveness analysis of any drugs going on. I didn't see that in the process. There's no cost effectiveness analysis. So we're not really sure in terms of is the drugs we're choosing cost effective or not on the basis of that.
No.
And then you're based on a fixed budget. You're basically negotiating proposal. I am assuming this is proposal on collection of drugs with some pharmaceutical companies. Then you're doing your prioritization process. When you do your prioritization process compared to the to the previous period, some people will be worse off and some people will be better off, I suppose. So there are some losers and there's some gain in welfare and there's some loss in welfare for the population. Now, since we don't have a cost effectiveness of drugs.
Well, there's a few misunderstandings here because I sort of abbreviated it in a sense, but I didn't say there was no evaluation of the drug. What I said was instead of just an evaluation of the drug, there's an evaluation of a proposal as a whole. So it's the proposal that's important. The cost effectiveness of the proposal is assessed.
So is there, that's my question, is there a body that's responsible for the evaluation of the proposals, of those proposals based on the welfare that has been gained and the welfare that has been lost, the loss of the welfare in the population that says that are we having good proposals? Are we having proposals that generate a net positive welfare for the population? Because we don't, if we're not doing an evaluation for the loss and the gain of the welfare of the population, we don't know actually if the proposal is efficient.
Sure.
From the perspective of society.
So there, I mean, the New Zealand approach fundamentally is a cost per quality analysis, right, with a few wrinkles around the side, which is not much different to anything else being done in the world, right? I think the Israeli approach is actually a little more expansive than that, might be the way to put it. In other words, and Bruce can talk to this, but he made mention of the fact that beliefs were really important in terms of the decision making, right? So what that tells me is, you know, what we value in terms of health gain is something that's is critically important to the decision making that's going on here, right? It's just not being expressed, say, in terms of a cost per quality. It's being expressed through a committee having to make a bunch of choices at a particular point in time. Now, your issue about, well, does that mean there's welfare, you know, the next committee might make a different set of choices and there's some welfare losses and welfare gains, etc. You know, some winners, losers in a statistical sense, right? I don't know the answer to that. Maybe Bruce can talk about that. But in the New Zealand system, no, that's not what's going on. It's being done using essentially the same methodologies through time to try and arrive at, you know, a welfare maximising position given a budget constraint. Right. Now, QALYs are not enough. I mean, in the New Zealand system, it's very well acknowledged that QALYs don't you know, the standard cost effectiveness analysis is not enough. You need to include more than just quality adjusted life years to denominate value or benefit in health. And I think the Israeli system probably is a more well-developed, it takes a more well-developed approach to that, except for the issue that you just raised about differences across the years, across different communities.
But is there like a framework, not qualities, if we say, okay, the qualities are not the proper measure, or maybe cost utility studies or even cost benefit studies that are going on in terms of, is there a framework just to evaluate this thing? Are we going in the right direction?
So let me talk about how we do it in Israel. So in Israel, for sure, they're thinking about the costs and the benefits of each drug. And when the committee, again, they're generally lay people, but the technical people prepare them for each drug that's, first of all, they do it in two stages. The ones that really have no chance of getting through, they drop out. But the ones that have a chance of getting through, the committee gets, you know, a fact sheet about each of them and a summary page. And for each of them, they know how many people it's going to affect and what's the cost per person going to be and what's the expected benefit going to be. They don't reduce it to one number. Now, my friends who were, you know, policy wonks who specialized in pharmaceuticals, they say, oh, well, we have to have a price discount. You ought to summarize up into one number. And maybe they'll go in that direction at some stage. At this point in time, they sort of give them 3 parameters for each of them. The number of people affected, cost per person, and expected benefits. And so you know, they're not doing the technocrat's dream of reducing everything to numbers and equations, but they are prioritizing based on those major parameters of value for money. And I just wanted to make a little pitch. Khalid mentioned before that we have this journal in Israel, which is a very unique journal. We publish empirical work about Israel, and then we get people from abroad to write commentaries about the international implications of it. So, for example, Vardit, who just joined us, who's based at the University of Montreal. So we had a really cool article about reproductive health, an aspect of reproductive health in Israel and ethics of cross-border flows of eggs. So she's an expert in that, so we invited her then to write a commentary on it. And similarly, so we have this guy who writes a lot about how decisions are made for our benefits package, and we have a colleague of yours from New Zealand, what's his name?
Paul Hansen.
Paul Hansen, he writes commentaries about it. And we think that's a really neat way to do cross-national learning, because you can't just come from one country and pronounce things, but if you have this real, in Israel, in Hebrew we have this term chavruta, where two people grapple together over an issue. They might disagree, but it's through that working together that you really do the best learning. So we try to do that a lot. So I asked Colleen to get everybody's emails, because you may be getting requests from me to write up commentaries.
Yeah, that piece of paper's flowing around somewhere, so if it's got stored somewhere, could you grab that? If you would like Bruce to email you about this or that or the other, I'll put your name and email down there. I think one of the things that didn't just come out from that question, which has always interested me, is that in New Zealand, things are very rarely delisted, right? Things don't come off the formulary as a result of re-ranking. It's just is then used as a leverage for enhanced negotiations with the drug company. So now if your drug is not as valued as highly as a new drug, perhaps that's come along that is more beneficial, this just leads to the ability for PHARMAC to negotiate the price. So drugs aren't going, you know, this idea that you're losing welfare, the point that you made up the back, people are still getting their drugs, they're just getting it at a better price. And so that's the tension that comes along from taking more of a commercial perspective on that. So
I was under the impression that some drugs they would have to let go of them because they became maybe too expensive, or maybe not.
I don't think
or
that.
maybe they have to do some other choices.
In Israel, sometimes we say no, we let go. Sometimes we say no.
Sorry, you have 2,000 drugs on the New Zealand formulary.
Yeah.
I think it's 4,500 on the Ontario formulary. That's quite a disparity, right?
Yeah, but you know, what makes up a lot of that difference is you list, like in New Zealand there's one generic, there's one brand of one generic, right?
Oh, so all the different generics are counted as different products. And then
Exactly. So you get thousands more on the Ontario.
Okay. Vadi, and then is it on this point? Would you like to?
Oh no, it's on the other.
Okay,
I was
Vadi.
just going to make one on that point.
Okay.
I don't know if you just followed up on that question, but Bruce, when you had that sort of big proposal you're talking about, and I'm not sure if this is what he's trying to say, but are there any specific, like, explicit weightings to those components, or are they all? Is it just like you take them differently, a randomized approach each time, or are there explicit weightings to each one of those components, utilities that comprises the whole proposal?
So formally not, but researchers, the one I had up before, they try to like interview people or look at what they chose and try to reverse engineer and figure out what the weights people used were. And there'll be public discussions as well as discussions. The committee doesn't just talk about specific drugs. They also go away for 2-day retreat and talk about the more deeper issues. So for example, how much emphasis should we give to drugs that'll give people another 2 months to live, and to what extent should equity considerations be a factor? Drugs that are particularly important for low-income populations. So they'll take those steps back and they'll think through their values and weights. But it's not formulaic in the end. And again, it drives my policy wonk friends crazy because, there's going to be all this noise in the system. But these public figures say, we don't think that way. We think in more gestalt, and that's what they're expected to do.
Savati.
Sorry for the late arrival. So 2 comments. Israeli society is very communitarian when you compare it to North American society. It's been well documented in many ways that the social capital, what we call here social capital, is very high. So Bruce, you said sometimes we have to say no, and people are used to life and death decisions and people just live with the consequences. And I'd just like to mention the role that charity plays. When these vacuums are created, there are NGOs, there are you know, even fundraisers through social networking that I'm exposed to all the time, where there's a tendency of society to fill in those gaps from private pockets where the real need of a specific family is identified. So can you say a word about that? I'm really fascinated to know if there's any research about this Israeli tendency as compared to other countries, this way of filling in the gaps.
So I don't know the overall picture, so I don't know comparative, but I can tell you just from one study I did 15 years ago in Jerusalem. In general in Israel, you can't pick your doctor in a publicly funded hospital. That's one of the reasons people go out of the system and go to private hospitals to pick the surgeon. But in the Jerusalem nonprofit hospitals, if you pay extra, there's a special program, you can pick your doctor. And we did a study who does it? Is it for which types of illnesses do they do it? So it turns out in general there's an income gradient because it costs money, right? So it's generally the rich people do more, except in our ultra-Orthodox population, the Hasidim, you know, the ones that dress a little funny. There, even though they're really poor, they use it a lot, and that's exactly what they do. They go, the rabbi writes them a little letter, and then they go door to door and they raise money. So it's more developed in some, at least historically, it was more developed in some. Before there was Facebook, it was more developed in that kind of traditional side than others. But I think it's also true in general.
Okay. So yeah.
So two quick questions. One is about generic pricing. So like Israel, Canada has a pretty significant generic industry with Apotex based in Ontario. And I think industrial policy through the pricing mechanism has often been why generic prices in Canada have been so much higher than even in the US. I just wonder, you talked about competitive tendering in New Zealand, which has kind of failed miserably in Ontario due to political pressures. What's the situation with the pricing of generics in Israel, and what does the relationship with Teva have to play with that? So that's the first piece. And then the second is, I just have no idea of how the interaction works in these two markets between the public plan and the private insurance. How that works. It's very convoluted, obviously, in Canada. Is it a little bit more straightforward given the universality of the plans in these two countries?
Well, I was potentially going to make a comment on the Ontario attempt at tendering, basically, in Canada, and I would say that it wasn't it didn't fail as a consequence of political problems, although you may have been closer to the action at the time. But there was clearly a lot of pressure brought on that tendering process that was attempted through the pharmacy chains themselves, through the ability of the pharmacy chains essentially to upset that tendering process. So, you know, my feeling, and I think there are reasons for that in terms of the way the tender was structured. So I think you could structure a tender here in Canada that would obviate those problems, right? So, you know, I wouldn't give up on the notion of sole supply tendering in this country for that reason. And interestingly, which you probably are aware of, Apotex competes in the sole supply tender in New Zealand and wins, right? So it could win here.
Quite easily. Put them out of business.
I don't know that it would put them out of business, but you know, there are plenty of markets that they're in around the world. They don't necessarily have to just get the highest price here. They could get the highest prices in Germany if you wanted them to.
First, I just want to say, you know, you're pretty fortunate to have right here in Ottawa someone who knows the New Zealand system and all its successes really well. I hope you're taking advantage of it. The generic pricing, I don't know the details of that. I can look into it and get back to you. My guess is that Teva might want higher prices for its stuff, but you have the countervailing force of the health plans, which probably have just as much political muscle, if not more, than Teva. And I think Teva's general strategy is, you know, to be low price, at least within Israel. I think they're trying to be low price. And again, this was a really small market, you know, so they make a lot of their money outside. And in Israel, you don't have the U.S., you know, over your border looking at you and watching that you're not. So we have more freedom. Private insurance. So half the population in Israel has private insurance through their health plan. And I'm sorry, 80% have through the health plan additional insurance. But those insurance plans are not allowed to cover life-saving drugs that did not make it through the through the committee process. They're not allowed to do that. The commercial insurance companies are allowed to do that, and they sell policies that do that, and those are held by 50% of the population.
50?
Yeah, that's it.
And so I think we have time for one last quick question, comment?
Yeah, I mean, I think kind of answered what I wanted to know, whether there was a distinction between market access versus coverage, so that if you didn't make it through the committee, could you still gain access to parts of the Israeli market? And it sounds like you can,
Yes. Yeah.
just not through the employer-sponsored funds, but through subsidiary funds outside of the sort of supplementary.
Right, but it's really important for them to get into the main bit package.
Right. Okay, so I think we actually have to wind up because it's time at 4:30. I know people have other things that they need to do. I thought it was a little interesting that we didn't really discuss access fundamentally and outcomes. And although we are debating pricing strategies and welfare loss about these kinds of decision making, we sort of managed to ignore that we in Ontario we don't cover people for insulin that they need, and we estimate about 800 people a year die under the age of 65 who live with diabetes because they're not accessing their insulin. So whatever the heck we're doing here, people, we need to make sure that people get access to the essential drugs they need. So with that, can we thank our fantastic speakers and commentators, and there's more coffee and more Danishes. Thank you all.